I should welcome you.
Yes, ma'am.
Good evening, everyone. Here we are starting webinar number 5 with Dr. Avneet here. She's the surgical oncologist practicing in Delhi right now in BLK Max Arcade, and she is the executive member of Delhi of our association. And women is an organization which we are starting for doctors to come forward for themselves, especially all women doctors of all the field, to what basic problems which all women doctors are facing in their working place. So we all here united for that, and this sequential webinar we are keeping so that we can keep upgraded for recent medical practicing things, and we should be get one platform where we can speak about our issues also at the same time and discuss medical things also. So I welcome Dr. Avneet here to start and make the cancer awareness CME, which is we all are waiting for since very long. Thank you.
Thank you, Soumitra, for the very nice introduction. So, I'm Dr. Avneet. I'm an associate consultant at BLK Max Super Specialty Hospital. I'm a surgical oncologist. So, we're all doctors here, we're all medicos here. So, why do we need cancer awareness? We're not layman people. So, with this webinar, let's just start. Where can we act? So this is a very elaborate diagram of the hallmarks of cancer. What exactly is cancer? So here, if we start from on your right side of the screen, if you see, let's start from anywhere here. But for my understanding purpose, I'll start from the genomic instability and mutation. So any form of cancer starts with a genomic instability and an underlying mutation. Okay, so this mutation can be genomic, like a genetic mutation, or it can be a sporadic mutation. Sporadic as in something that you have acquired on your own, or familial or genetic. It can be something that you've got from your parents or your family. So everything starts from this genomic instability and mutation. Now these cancer cells, after acquiring these instability, they become resistant to cell death,
Everyone
and
mute
they have.
themselves except Avneet, please.
So these cancer cells, they become resistant to death. They become resistant to death, and they modify their mechanism of developing cell energy. They do not behave like a normal cell. They behave like a super active charged cell who doesn't know how to stop. So they have deregulated cellular energetics. They just keep multiplying, and they multiply so much that anything that stops them, any kind of growth suppressors that they have, they evade these growth suppressors. They will avoid any form of immune destruction from our body, and they'll keep replicating any form of stoppage or inflammation. They will not they'll evade from any of that, and ultimately then they will start invading into other organs by making new blood supply, getting blood supply from the surrounding organs. And these cancer cells, they just they trigger their next cancer cell as well. So this cycle, this keeps on going and going and going. So these are the hallmarks of cancer. Okay, now why are we doing so much? Why are we studying so much about cancer and the hallmarks of cancer? Why? Because the cancer is the new epidemic of this century, and this is the latest data that we have from the Globacon 2022. And we're all Indians, we're all women, so let's just look at this cancer burden in India in females and in both sexes. So if you see on the first, second, and third, breast, oral cavity, and cervix, these are the first three most common cancers which are present in this country. And I'll tell you a fun fact: all these three cancers are preventable. They have screening modalities for all three of them. So, where do we lack? If we have screening modality for the most common cancer burden in India, why are we not finding cancers at an early stage or at a screening stage? Why is there so much mortality in this country related to cancer? So the answer comes to this WHO study which happened, that where do we lack? in finding cancers early or preventing them. So if you look at the base of the pyramid, it is the lack of awareness. So dear friends, my dear sisters, it's you, me, all of our doctors who have to work on the base of the pyramid, that is the lack of awareness. We are aware. When we are aware, we'll make other people around us, especially non-medicos, more aware. So they'll be asking you questions, and I'll help you, form your answers today in this webinar. So this is the same old PSM slide that we used to study earlier, the types of prevention, primary, secondary, and tertiary prevention. So we'll study it again once more. So what exactly is primary prevention? Primary prevention is you eliminate anything that can remotely cause cancer. So do not let the disease pathology begin. Eliminate any kind of thing that can cause cancer, or at least reduce the risk of it. Okay, so that is primary prevention. Secondary prevention is that the pathology has started, but you detected it too early for it to become something more dangerous. Okay, so you detected it at a pre-cancerous stage. Tertiary prevention is when you've caught the cancer, but you caught it at an early stage. So you helped in stopping the disease from getting worse. And this is, we all have to act on all of these three levels. We have to act on the primary prevention, secondary prevention, and tertiary prevention. So we'll start with the primary prevention first. How can we reduce or eliminate the risk of cancers? So okay, so when I say we will, throughout my webinar, I will be talking about screening protocols and vaccination protocols, or whatever protocols I talk. These are all for people of average risk. What do I mean by average risk? When you will be telling about any of your fellow peer or your family about screening protocols in India, you will be talking to them that they belong to an average risk individual. How do you know that you are from an average risk individual? You are not at a higher risk of getting cancer. Just because you're some random mummy poofy had cancer doesn't mean you are at a higher risk. There are laid down guidelines of indications of genetic testing, or the people who are at a higher risk, or the people who are at a higher risk of getting cancer, and the ones in whom these screening guidelines will vary a little. We'll have to tweak those screening guidelines later. So you should know who are at. Okay, so whenever you in your OPD are sitting, and whenever you take your family history, and something similar to this rings, you get to know something like this should ring a bell. Okay, so who are the ones with we have average risk, and who are the ones who have high risk? So any individual with a first or second degree family history of a breast cancer at the age of 45 years or younger, any cancer, any ovarian cancer, any male breast cancer in the family, any pancreatic cancer in the family, any metastatic prostate cancer in the family, two or more breast cancers with bilateral breast cancers, two or more individuals with breast cancers on the same side of the family at an age 50 years or younger. Just give me 1 second, please. Mutation. The third one is lobular breast cancer, a very rare kind of cancer. Gastric cancers. So if somebody who's had three or more individuals who had a lobular breast cancer, gastric cancer, it should ring a bell. So these are people who have higher risk than usual, somebody with such kind of a family history. Okay, so for them the screening guidelines will be changed a little. Okay, otherwise everybody or somebody who's had a personal history of cancer earlier, so these are not the people who fall into your average risk. Rest all of us will come under average risk of cancer. So I'll get back to our where we started from, the primary, secondary, and tertiary prevention. So primary prevention, so stop cancer before it even starts. Just do things that will reduce your risk of cancer. So this is again WHO who tells you ways to reduce your cancer risk. Do not smoke or use any form of tobacco. It's not just smoking, it's smokeless tobacco also, which causes various forms of cancer. Okay, healthy diet, breastfeeding your child for more than 1 year will reduce your chances of breast cancer by 2 times. Vaccinating your children against hepatitis B and HPV. HPV is a new thing, not really a new thing, it's been there for a decade, but we getting more and more data with the date that how HPV and vaccinating girls earlier in their career, in their life. If you vaccinate a girl at 9 versus you vaccinate a girl at 26, the girl at 9 will be protected more by the HPV as compared to a girl who's vaccinated at the age of 26. Both will benefit, but the one who got vaccinated earlier will be benefited more. Okay. Avoiding too much of sun, using sun protection to protect yourself from melanoma doesn't really matter much in India, but in US and other countries, it matters more. Reducing indoor and outdoor pollution, being physically active, limit alcohol intake. Alcohol acts as a synergistic with smoke. It increases your risk of cancer by fourfold. So, taking part in organized cancer screening programs, this is what we can do as a primary prevention. Other thing we can do, so HPV vaccine schedule, where all women, we all know at least 10 women around us. So please encourage people to have HPV vaccines as early as they can. The Indian government, they empower people. They've been telling people to get vaccinated as less an age as 9 years to 14 years, because first your dosing schedule will also decrease. If you're vaccinated between 9 to 14 years of age, you just need 2 doses of schedule to get adequately your immune system to get kicked in. If you get vaccinated above 15 years of age, you will require 3 doses. So get vaccinated as early as possible. So this was one part. You have to have a healthy lifestyle. You need to get vaccinated. These are all primary prevention. Now we come to secondary prevention. What was secondary prevention? We have to catch cancer before it causes symptoms. You have to catch it at a precancerous stage. So I told you the three most common cancers in India: breast, cervix, and oral cancer. All three of them have screening guidelines. So let's just memorize them at heart. Breast cancer screening, you started at 25 years of age. You provide breast self awareness. What is breast self awareness? You teach them how to do breast self examination. Okay. And after she's turned 40 years of age, you have to do annual clinical breast examination with mammography starting at the age of 40 years till the age of 75 years. This is when the previous mammograms have been normal. Till the age of 75 years, this is when the previous mammograms have been normal.
मेरा
This
नेटवर्क
is when the previous mammograms have been normal. Possibly a co-testing combined, which can be done separately, or we prefer doing if we're doing only pap smears and we're doing a co-testing at 30 years, 3 yearly till 65 years of age, provided all of your previous pap smears have been normal. Oral cancer screening, very very easy. You have to teach visual inspection both to the patient so that they can do a monthly oral self examination. You have to tell them what are the danger signs, and a visual inspection by the clinician whenever possible. Colorectal cancer also has screening protocols. You have to start screening colonoscopy at the age of 45 years, once in 10 years. It's a very doable thing. You have to do it once in 10 years, but prevents colorectal. It can prevent colorectal cancer from being detected at a full blown stage. For patients who are smokers, who are above 50 years of age, or somebody who's more than 50 years of age with more than a 20 pack year history, low dose CT scan, very safe. It's in the recommended screening guidelines. And PSA testings, there is not a very strong valid data as to sensitivity and the specificity of PSA testing. It varies from person to person, but we're all very easily we can access PSA testing very easily in this country. So PSA testing can be done for your father starting at the age of 50 years till the age of 75 years. No particular interval defined, but you can discuss it with your urologist based on what your initial finding was. So this was secondary prevention, where we started with screening. So when I told you we will teach, so first thing first, we'll talk about breast cancer. So at any girl who's 25 years of age and above, let's teach one more girl how to do breast self examination. Very easy to do. If you're a premenopausal girl, preferably 7 to 10 days after your periods. If you're a postmenopausal, just fix one date, and you have to do inspection and palpation. Simple things that we learned in our MBBS. You have to inspect. You have to inspect by raising your arms above your you have to raise your shoulders above and inspect for any kind of changes, any redness, dimpling, puckering, nipple changes, changes in color, surface of the breast. After there are no changes in the inspection, you have to palpate either clockwise or anti-clockwise from the center to the periphery, and then going to the axilla and then to the opposite side. If there are any form of abnormal lumps, nipple discharges, any form of excoriation of the skin, or any kind of lump, or any abnormal finding that you find, you have to get yourself checked. Cervical cancer, as I told you, the screening starts at the age of 25 years. If you're doing only pap smear, if you're doing a co-testing, it has to start at 30 years of age. So India has tweaked its screening guidelines as to people who stay in low resource settings. So if you are staying in a good resource setting, the patient is affordable, you can do it. You should prefer doing it at 25 years of age. If you're staying at a low resource setting, you can start at the age of 35 years. Even in patients when you do not have the access to HPV testing, via is a very very easy to learn, very there are a lot of programs of how to teach colposcopy, how to do visual inspection with acetic acid. It's another way of getting screened. So in low resource settings, whenever possible, go for HPV co-testing, but whenever not possible, via, that is visual inspection with acetic acid, every 3 to 5 years, starting at 30 years of age. If you're in a good resource setting, please go for a co-testing at the age of 30 years, and you have to do it every 5 years. So this was the vaccination, the primary prevention that we already talked about. For oral cancer, you have to sensitize every medico, which includes any doctor, dentist, or even your ASHA workers or paramedics, how to determine any kind of a oral precancerous or anything abnormal in your oral cavity. So what can they do? Any ENT specialist, dentist, surgeon, oncologist, or even a trained paramedic can they can identify a suspected oral cancer. So you have to tell them what are oral potentially malignant lesions. Okay, so if they find an oral potentially malignant lesion, they have to push for elimination of etiological factor like tobacco cessation. After this tobacco cessation, you have to observe for 6 weeks. If it regresses, you have to tell them to visit a doctor, and they have to get reinforced at counseling. If there is no change or there's progression, or if there is any oral cancerous kind of lesion, immediate referral to a doctor is required. So when I say potentially malignant disorders, what are these potential malignant disorders? These are, so now there is a new terminology called oral potentially malignant disorders. These are pre-malignant lesions and pre-malignant conditions. I will be showing you the most common three that we see in India. These are pre-malignant conditions. If caught early, can help in preventing cancer, can help in detecting cancer in as early as possible. So on the top you have leukoplakia. It's a whitish plaque which does not get rubbed off. Okay. Below that there is erythroplakia, similar thick plaque which is reddish in color. Okay. And other than that, there can be oral submucous fibrosis, which is again seen very commonly in people who use smokeless tobacco, khenny chewers especially. So what kind of symptoms will happen in oral submucous fibrosis? The patient will have reduced mouth opening because there will be submucous fibrosis which will be happening in the mucosa all over your oral cavity. There will be tightness or stiffness in the cheeks. There will be reduced mouth opening. There will be burning sensation whenever they eat spicy food. There will be red patches, ulcers, or white specks in the mouth. The inner cheek will be thickened, it will not be soft as yours, and they will have difficulty in speaking and chewing because of this increased fibrosis. If you see anybody with such pre-malignant lesions, you have to encourage them to leave tobacco in every form and refer them to a doctor. So now we've done with the primary prevention, that is how to prevent cancers. We've done with the secondary prevention, how to prevent, progressing to an invasive disease. Now come to tertiary prevention, how to catch cancers early. All of us should know system-wise the symptoms of cancer, so that caught early, treated well. Okay, so what are the signs and symptoms of various kinds of cancer? So you have to pay attention to your body, because you will know what abnormal is going on. You have to tell people that these are the symptoms of cancer. If there are any of them, you have to report. So start with the gynecological cancer. So ovarian cancer is the biggest demon, because it comes with all sorts of non-specific complaints which can happen. So any form of loss of appetite, feeling full, gas, indigestion, bloating, nausea, frequent urination, any form of pelvic pressure, which might not feel ominous but is ominous, because ovarian cancer is a demon. It will cause all form of weird, unwell, specific, non-specific symptoms. But if you are aware, you can probably get patient tested, probably do a ultrasound of the abdomen or a TVS with a CA-125, and can catch cancer early. Uterine cancer, on the other hand, that is endometrial cancer, is often found early, because you know, it has this particular, most of the uterine cancers present with postmenopausal bleeding. So, they can also present with irregular bleeding or heavier bleeding or pelvic pain in cases of premenopausal women. But for a postmenopausal women, postmenopausal bleeding is the most common symptom of uterine cancer. Vulvar cancer, any form of constant itching or burning of the vulva, any form of plaque on the vulva, any form of lesion formed on the vulva, rash, sore, or warts, these can be vulvar cancers. Vaginal cancer can also present with postmenopausal bleeding. It can present with pain or bleeding during intercourse. It can present with a frank vaginal mass. Cervical cancer. So cervical cancer, it's what we by standard learn is post-coital bleeding. So that is the most characteristic of cervical cancer pain, cervical cancer bleeding, post-coital bleeding. But it can also present with simple vaginal bleeding, which is not related to your menstrual period, postmenopausal bleeding, or some form of foul discharge from the cervix or from the vagina. So these are some of the symptoms of the gynecological cancers we have to be aware of. Gastrointestinal cancers, some symptoms that we should not ignore. If somebody who's coming to your OPD and they've been telling you that they've not been able to eat properly, they were able to eat solid food probably a few months back, now they're getting on semi-solid, and suddenly now on liquid diet, and because they're not able to eat anything. So dysphagia, persistent heartburn, or chest pain, something that internal medicine doctors often come across. So other than that, stomach indigestion or sensation of fullness after meals, very characteristic of stomach cancer. Somebody who has a vomiting probably once in 2 days. They eat and they're able to, they're vomiting once in 2 days of whatever they're eaten in 2 days. Very characteristic of gastric outlet obstruction. Colorectal cancer, again a demon. It presents with all form of weird things like change in bowel habits or even anemia. So I've seen many doctors, many peers who have missed a colon cancer. One of them, a very close friend of mine, an anesthetist, uh, who ignored a colon cancer, a healthy male of age 60 years, who was a runner, who was eating all healthy diet, suddenly presented with a hemoglobin of 6, and she prescribed them iron and blood products. Uh, that is one thing that you don't have to miss. Any healthy male more than 60 years of age presenting with unexplained anemia, presenting with anemia, uh, you have to rule them out for colorectal cancer. Please refer them for a screening colonoscopy. Any patient who is presenting with jaundice, any form of right abdominal swelling, right side abdominal pain, can present with liver cancer. Pancreatic cancer, very characteristic back pain, because that kind of referred pain. So you find out many people who come with back pain and they've been repeatedly given painkillers for back pain, not being evaluated for pancreatic cancer. Or new onset diabetes mellitus, also ignored symptom of pancreatic cancer. For breast cancer, then again, we've all learned breast self examination. Now, what to look for in a breast self examination? What all do you have to see? Most importantly, lump. Please go to your breast surgeon or a breast doctor if you feel any kind of breast lump. Other than that, there is any recent onset retracted or inversion of nipple, any dimpling on the skin, any form of nipple discharge. Now, nipple discharge, again, omnious kind of nipple discharges are, spontaneous. They say 4S. Spontaneous discharge on the single side with a single duct, which is serosanguinous in nature, reddish white color, spontaneous discharge, not on pressing. So this is omnious of cancer. Any form of newly developed redness or rash. Okay, so these are, or any form of lumps which are found in the axilla. These are all signs of breast cancer. Head and neck cancer is also, some form of sore throat or, a kind of lump in the neck which a patient has been, feeling for the last 3 to 4 weeks. Do not ignore it. Any form of sore throat, any form of frequent nosebleeds that could lead to some form of invasion in the maxilla or nasal cavity. Trouble swallowing, this can be a supraglottic cancer. Changes in the voice, this can be a glottic cancer. Ongoing nasal stuffiness, this could be invasion of the maxilla or the nasal cavity. So somebody who's coming to you, all my ENT friends here, all my non-ENT friends here who've been coming to you for these persistent complaints, do not ignore them. Urological cancers, testicular cancer, again, now we all know it's not internist tumor anymore, it's a radiologist tumor. It's caught incidentally, but one of the most commonly missed kind of you know tumors are testicular tumors, because often patients come with probably a heaviness in the testicle or a testicular mass, and often they do not get examined. They're examined for everything else, but they don't get a proper testicular examination. Or there is any form of, retroperitoneal mass, please examine testes for that. You might be missing out on a testicular cancer. Or bleeding during urination, trouble in the emptying of the bladder, difficulty in, any form of urinary complaints. You're not able to stop urination, or there is frequency, urgency of urination. These can all be symptoms of urological cancers. Okay, lung cancers again. So, any form of cough that is lasting for more than 3 weeks, if there's a blood in cough, there is sudden onset of hoarseness, loss of appetite, sudden unintended loss of weight, feeling of weakness or tiredness which is persisting for more than 3 to 4 weeks, somebody is presenting with the shortness of breath and there's no explainable cause that can be found, please investigate the patient further. So I've told you all these, system-wise symptoms of cancers. Why did I tell you? Now the patient already has cancer. Why did I waste all of your time to tell all these symptoms? Because if you catch it early, if you catch it at stage 1 or even 2,
It's
your
my
survival
network
rate
issue,
will
or
improve
everybody is not
maximum.
able to
So
hear.
any
It's
cancer
crack
caught
in
at,
voice.
stage 1, stage 2, your survival will be very good. Any cancer.
Break in voice is for everyone, or it's for me only? Hello? Hello?
Uh, I won't be able to tell because I can hear you clearly.
Okay. For me, it was like a break of voice was there. Okay, you continue.
Okay, so catch it early so the survival is better, the quality of life is the same. Okay, now why should there be a dedicated referral to an oncologist? Why can't just any specialty treat cancers? Because today it's the molecular subtypes, it is the biology which rules the oncology. It's not the oncosurgeons or the medical oncologists, it's the biology, it's the molecular subtypes of cancers. So cancer now is not treated just as a site specific cancer, it is treated as a site specific molecular specific cancer. So all breast cancers are not treated same. Now, breast cancers are of 4 types, all of them treated completely differently. Oropharyngeal cancers are of 2 types, both of them treated completely differently. Endometrial cancers are of 4 types depending on their genetic mutations. All 4 of them will have altogether different prognosis, different kind of adjuvant therapy that has to be given in all of them. So, if you're particular subtype, not any XYZ should treat an oncology patient. A proper referral is very, very necessary because, missing out on that very one important update and very important link can lead to a very big loss to the patient. So, a proper referral to an oncologist whenever a cancer is suspected is very, very important. Why are tumor boards important? So it's, if I'm an oncosurgeon, I have no right in this world to decide what all therapies will my patient get. Tumor board is the way to go. What is exactly a tumor board? A tumor board is a board of people in which ideally each and every patient should be discussed in a tumor board. So what exactly is a tumor board? It contains people from all fronts who will be managing that cancer case. A surgical oncologist, a medical oncologist, a radiation oncologist, the pain nurses, the radiologist, the nuclear medicine, the pathologist who looked at the slides and everybody, they all should be ideally discussing every tumor board. Although in most of the institutions, the complex cases, not very standard cases who are discussed in the tumor board, but ideally every case should be discussed in the tumor board, planned properly, and then given the treatment. And especially being in an oncology unit, being in a high volume oncology center, sending your patient to an oncology center will help them because they can also, because of their better experience, cater to special needs like somebody who's probably fertile. You know, give them fertility preserving options, treat them differently, treat them in a more specialized way if they're somebody who has adolescent and young adults cancer, and better palliative options in patients who are caught at a late disease stage. Palliative is coming big way. Even stage 4 cancers, they often live longer comfortable lives thanks to the great palliative teams which are coming up. So now I would like to discuss 3 good cases with you, which I came across in the last 2 months. So this was a 50-year-old lady who came with a large TNBC tumor on the right side, and because I told you. Breast cancer is now completely revolutionized thanks to the molecular subtypes, because it was a TNBC, that is a triple negative subtype, very, very chemosensitive. We gave her chemotherapy and immunotherapy. The patient had a near pathological complete response, and 3 weeks after 3 months after the treatment completion of the breast conservation surgery and the radiation, even the patient could not tell which side of the breast was the surgery done on. So this is one of the great advances of breast oncoplastic surgery which is coming up. Second was this Lamin. This is a staging laparoscopy of a low-grade appendiceal neoplasm, which was done. Her PCI was above PCI, peritoneal carcinomatosis index. That is, the disease was spread everywhere in her abdomen, like everywhere. There was no single place where the disease was not there. But because disease biology, she was a low-grade appendiceal mucinous neoplasm. All the disease was taken out after a long 13-hour surgery. She's cancer free. She's 6 months post treatment, completely cancer free. Also, another patient, we had a 85-year-old early rectal cancer, which was found early. He was not very keen on getting operated. He underwent a complete total neoadjuvant treatment. There was no residual disease left. He's kept on the wait and watch scenario. So there are advances coming in oncology every day, site specific oncology, organ specific oncology. So whenever you catch a cancer, please refer the patient to an oncology center, somebody who's been managing it more you know comprehensively, and try to spread as much knowledge of the cancer as possible. It's completely revolutionizing. So what is the future? What does the future hold? Next generation sequencing. What exactly is next generation sequencing? It is a genetic test which codes your entire genome, finds out the so any stage 4 cancer or an early cancer. Next generation sequencing can help patients who are in even stage 4. If they find a targetable mutation, it can save lives. Liquid biopsy, they can help in detecting cancers early. AI in oncology is helping in planning treatments, planning various prognostic markers which are coming up. So this is what the future beholds. So, like my boss always said, I love this line that he said: the first treatment has to be the correct treatment. That is the only norm in oncology. First treatment has to be the correct treatment, because cancer doesn't give you a second chance. So whatever you do first, it has to be absolutely correct. It has to be completely scientific, evidence based, and it has to be multidisciplinary. You cannot decide whatever your patient will get. It has to be a team effort, because our patients, they literally deserve the best. That is all from my side.
Thank you, Dr. Avneet. You rightly said in oncology, it's like we have to give the best. First chance is the best chance. And if we patient got the first treatment, ideal treatment, then I think patient should not come to us second time. Although the recurrence is based on the tumor biology also, and disease specific prognosis also. But yes, if patient comes to us, and being an oncologist, we should try our best to give the personalized patient care for the each patient, so that it's a duty of a oncologist. That's the best thing. What at what setup, since you are in Delhi or with all good best facilities at your place, we are in two tier cities, we are struggling with the genetic testings and all, and patient wants the best care. So sometimes we have to decide pros and cons. If we will say for each and every patient to go for genetic testing, then we might patient not get treated only. So all these things we have to see. Matlab, this is the oncologist perspective. Every oncologist, we should decide according to the patient, कि how is the patient, how is the mentality, how the patient will think. And
Completely, I completely agree, Samita.
uh, but being not, if there is no oncologist and you are getting an oncology patient, then me and Avneet both are available. You can discuss with us what treatment you should give to the patient. We can have one discussion, and you yourself can give the treatment if in your setup oncologist is not available. So for this, I think Avneet and me both will be available in our group if you people
Yes,
face such issues.
we're
Uh,
happy to discuss
huh.
every case.
If you are in district place or you are in a government medical college where oncologist facility is not available, so we will happy to help you all. This is the main. And basically cancer awareness, for us, we are knowing what is the cancer, but for us ki we should see the patient and we should detect the patient early. So early, if patient comes to us, it will be always earlier the stage, better the prognosis. Leena ma'am, please conclude the session, or if anyone have any query they can ask.
Hello, very good evening. And Dr. Avneet, it was a wonderful presentation, and I was like, it was so clear ki what exactly, in short, we should know, because we can keep on speaking on any cancer at so many days, because years we have spent on these all these things. So,
Yes,
in a
ma'am.
nutshell, whatever was required, it was very well told to all of us, because many of us also don't know the screening protocols, and that was so wonderful. And
Thank you
it's
so
so
much, ma'am.
lucky to have you over here. And Someta, thank you for bringing her on this platform. And because women has got like we have the motto of our Women's Medical Alliance is like we want to help each other. whether we are remotely seated in any tier city we are there, we should help bring a circle, such a strong circle that nobody dares to touch anyone or can demotivate or demoralize. We should all unite together and grow together in every field. And cancers per se are, you all know, worldwide the incidence is growing like you can show it is like that logarithmic equation is going on. It's not just simple addition or multiplication, it is growing logarithmically. And so you have expressed your things very well, and hope to be in contact in future for any queries which anybody is facing all over India, so we can have that. So
That's
thank you
why
so
we
much.
have our slogan, na ma'am, fearless in healing and united for the purpose.
Yeah, yeah,
So
so true, and we want to spread this awareness to all. So good was the lecture that, but I feel ki there should have been much more attendance. And okay, we will provide the recording so that everyone should get benefit in our channel. We will add, so it's like that. So thank you everyone who has joined, and Dr. Avneet, thanks once again to you.
Thank you so much,
Avneet, you
ma'am.
have to become more attentive for not only for cancer part but also for women doctors awareness.
Yep.
In cancer
Noted,
part
madam.
you are very active, that I know, that's why I have
Yes.
given you this topic, but women upliftment में थोड़ा lacking है. अबे
That's there,
ग्रुप
madam.
में सिर्फ 3 ही लोग हैं इसलिए मैं ये बोल रही हूँ.
Correct,
Yeah,
correct.